Hello, and welcome to another episode of Vital Times, the CSA's podcast. Today, we're going to talk about the new federal healthcare cuts and its effects on, in particular, rural healthcare. I was interested in this topic after reading a CSA Online First blog by our three guests today on this very topic. Not yet doctor, but soon to be Dr. Charley Yan is a fourth year medical student at UC Davis with a background in Medicaid policy. Before medical school, he helped drive California's Medicaid expansion efforts and has since analyzed coverage and safety net policies across multiple states. Dr. Mary Morales is an adult anesthesiologist at Stanford. She is the current vice chair of the CSA's Justice, Equity, Diversity, and Inclusion Committee, affectionately known as JEDI. Dr. Naileshni Singh is a pain interventionalist with a background in anesthesiology from University of California, Davis. She is the current chair of the CSA's JEDI committee. When Congress celebrated the new House Resolution 1, also known as the One Big Beautiful Bill Act, experts warned of massive impacts on the Medicaid programs nationwide and the fact that there was more than 70 million people who rely on them. H.R. 1 cut nearly $1 trillion from Medicaid, the largest funding reduction in the program's 60-year history. The Nonpartisan Congressional Budget Office estimates that by 2034, as many as 10 million individuals nationwide will become uninsured as numerous new eligibility rules imposed in the Medicaid and the ACA programs are lost. In California, the Medicaid program is known as Medi-Cal, and it covers more than half of the state's children and 2.2 million seniors and people with disabilities. 1 in 5 working Californians and millions of other people with low income are also on Medicaid. And H.R. 1 is expected to cut $30 billion a year in federal funding from Medi-Cal. I want to try and understand this topic a little bit better. And so I'm going to start with Charley Yan, who worked in Medicaid policy and understands this, I think, better than any of us on this call. So can you explain to us, Charley, why Medicaid is important to rural communities?
Just want to give a little bit of background of how we define rural communities in California. So rural California specifically is home to more than 2 million residents, around 6% of the state's population. And it's not just Northern California counties. Every county in California, except for San Francisco, has rural populations. And 6 counties in California are entirely rural. So even though it may seem like a small population, it's very expansive and vast in our state. The reason why Medicaid is really important for these communities is because it covers a large portion of this population. Compared to their urban counterparts, Medicaid covers more than 2/3 of adults in rural districts versus 1/4 of urban counterparts. And the way Medicaid covers this funding in hospitals specifically is that there are these things called disproportionate share payments. Medicaid pays a higher rate for these rural communities. And when you cut Medicaid, these payments fall and more people fall off care. And so these hospitals are getting less revenue.
Wow. So I just want to understand that. So every county in California has a rural population. Is that did I hear that right?
Yeah, and I think it's something to take into account. So pretty much every county in California has some kind of rural population.
And then Medicaid is the insurance that covers 2/3 of all adults. And I already said 1/2 of all the state's children are covered by Medicaid, but it covers 2/3 of all adults in those rural populations compared to 1/4 of all adults in urban populations. Is that also correct?
Yeah.
Wow. Okay. And you said 2 million people live in rural communities?
It's more than 2 million. It's around 2.3, but just want to benchmark it at that.
Yes. Okay. 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 Um, I want to, before we, because I think we're going to try and really jump into kind of what all of this means and how this is really going to impact people who live in these communities, but also physicians and anesthesiologists who provide anesthesiology care in these communities and its impact on hospitals. But before I get to that, I'd like to turn to Dr. Morales and Dr. Singh and ask them how their committee, which is um, the um, the JEDI committee, which stands for, again, sorry, the Justice, Equity, Diversity, and Inclusion Committee, got interested in this topic. Oh, we'll start with Dr. Morales.
I believe Dr. Singh had something prepared for our introduction of our committee.
That is perfect. Then we'll go to Dr. Singh.
Thank you, Rita. So, our committee is working on awareness in regards to disparities in healthcare. And when you think of rural California, rural America, they are disproportionately affected by disparities already in health care delivery, but will also be disproportionately affected by these cuts in Medicaid and other funding sources like the Affordable Care Act when all of this comes to fruition, and everything will January 1st as the new fiscal year begins federally.
Dr. Morales, is there anything you'd like to add?
And, I think as being leaders in our field, it's incredibly important to be in the known when it comes to what's going on with legislative changes, what's impacting the patients that we serve, the communities that we serve. How can we do our part to continue to ensure that we're providing high high level quality care and compassionate care for all of our patients across all our communities. So when big changes like what's happening now with the legislative changes as it relates to healthcare funding across the country, it's incredibly important for all of us to stay up to date and stay educated on this so we can know how to best support our communities going forward.
What are some ways that we could um, prepare to treat some of these changes that are going to be coming? I've read and heard that there's real fear that there's going to be a lot of, in particular, again, rural hospitals that are going to have to shut down and that patients are going to be left without any place close by to go for care. I'd love to hear from the three of you. We can start with Charley and then Dr. Singh and then Dr. Morales, if you'd like, to give us, just your thoughts on what anesthesiologists, what physicians, what people who care about their community can do to try and prepare for these dramatic changes that are going to be occurring.
Yeah, so I can talk a little bit about the assistance that's coming from the policy perspective. So national funding is going to be cut, but the state is trying to make up for some of that shortfall. Um, if you look in March, the state took out several $billions in loans to continue funding the program and probably provide some supplement for the cuts that are happening, but not enough. Federally, Congress does recognize that these cuts are going to impact these communities. So they've created a rural health fund that provides funding for some rural coverage, but estimates show that it doesn't even cover half the cuts that are being made.
Mm.
So there's, like, long story short, there's some supplementary coverage and funding being provided, but not enough for these communities at the moment.
Dr. Singh, would you like to add any thoughts or comments that you have?
Yeah, I mean, the scope of this problem and this issue is starting to become really focused. We know that rural California is going to lose approximately $2 billion worth of healthcare funding, and 135,000 rural residents are potentially going to lose their health coverage. So when you think about this and you think about what does Medicaid cover, well, in our state, like in a lot of other states, it covers nearly half of all births. Fetal care, child care, 1 out of 5 inpatient discharges in rural communities. It even covers kind of skilled nursing facilities, etc. So we're going to see this tremendous shortfall, and it's going to be proportionally felt in these communities that already had challenges in getting healthcare systems running, getting specialty care, having surgical services that are close by, and even emergency services. So, our prediction is that this is going to also affect care that's not necessarily typical, like, or very lucrative, like behavioral health, coverage for medication assisted treatment for things like substance use disorder. It's probably going to affect a lot of Americans between the ages of, say, 27, when they may not be able to get on their parents' healthcare coverage, all the way up to just before they qualify for other sources of coverage like Medicare.
Thank you. Dr. Morales, is there anything you'd like to add to that?
Yes, and I just wanted to add, the problem is not only just affecting our state of California, it's going to have a huge impact across the entire country. Charlie had mentioned earlier, no, there's like 2.3, around 2 million people in California itself that live in rural areas, but when you start looking at the broader country as well, you're looking at almost 20% of the US population that lives in a rural area. And these are the areas that are going to be disproportionately affected by these changes in legislative and how we approach access to care, how the government approaches reimbursement process. And all these healthcare centers and hospital that operate in these areas that are already underserved areas to begin with are already doing so with very, very tight budgets. These locations, these hospitals and healthcare centers already operate on a very, very thin margin. So now you're asking them to provide what they're already having a difficult time doing with even less.
Wow. Yeah, it's so interesting, and I'm sure I'm not the only one, but I don't understand. I don't understand why. Like, why did our government think that this was a good idea? And I do. Before I get to that, though, I actually wanted to ask one of you, if you don't mind, going over what the changes actually are. Um, Dr. Singh, did you want to take that?
Sure, yeah, and Charlie can chime in. So, what the changes are is actually, in some ways, it's not just a bulk of money being taken away from people. Really, there's going to be a lot of structural changes to enrollment in Medicaid. For example, there's going to be more work requirements, more procedural barriers that will just lead to more people falling off of having that type of insurance, even though they might qualify. So, not only will there be cuts to providers and hospitals, there will also be all these barriers to actually even getting enrolled, and you'll have to do more frequent check-ins, for example. Now, if you live in a rural community that may not have great internet access, that you may not be very well educated, not being able to fill out the forms, and now you have to do that very frequently, or you have an employment situation that can be spotty. Those are things that will prevent you from actually enrolling in Medicaid. So that is one way that the One Big Beautiful Bill will be seeking to kind of underfund healthcare over time as a way to save money in the entire system, which is essentially creating barriers that will disenroll individuals. So that's one way. The other way, of course, is the underfunding or the lack of funding of the Affordable Care Act, which is federal legislation that came out during the Barack Obama presidency that provided essentially subsidies to insurance companies to lower their premiums and costs so that people who did not qualify for Medicaid, but also didn't qualify for Medicare, could get health insurance coverage for themselves and their families at a lower rate especially in case if they didn't have employer-based care. So with the Medicaid funding cuts and the lack of subsidy renewal for the Affordable Care Act, we're really at this situation where it seems like everything's going to kind of collapse around us unless there's very quick movement on these things. Now, Charlie mentioned that California is trying to look at ways to kind of fund it themselves. So that is one avenue that a lot of states can take, where they can take out loans, they can use their own funding, or pass on the cost to health systems or the patient themselves. But as we know, that's very difficult to do, because a lot of individuals will simply prefer to lose care versus trying to get care that they simply can't afford, because they have to pay for rent and groceries and childcare. All of those other things are also very expensive. And then you tag on these costs to healthcare. I mean, there are estimates that because of these dual crises going on with the underfunding of Medicaid and the Affordable Care Act issues, people are going to be paying double, triple, even quadruple of their typical premiums that they used to pay last year. And this is true of California and of other states. Premiums are going up across the board because of this underfunding issue.
Charlie, did you want to add anything to that?
Yeah, I can talk a little bit more about the policy, but I think Dr. Singh put it perfectly, actually.
Yeah, great.
So I just want to say that a lot of what Dr. Singh talked about, like the implementation of work requirements, which are the barriers, and also the absence of premium subsidies that are going to take into effect next month potentially, are all things that have kind of been studied. For example, in work requirements, they implemented those in Arkansas and Georgia, and we looked at the effects of those policies, and it turns out they didn't work at all. What happened in those states was essentially that those states paid $50 million to consulting companies to put people off healthcare. So it was essentially what we don't want to see in healthcare, which is creating more administrative bloat to take people off the healthcare system. The same thing goes for looking at the effects of cost sharing, which is another thing that they're doing that Dr. Singh talked about. Lots of studies have been done on the effects of cost sharing, and they show time and time again that when you implement cost sharing, it takes people off their health insurance. And so we know the impacts of these policies. It's not something that we're just proposing or guessing.
So then I guess let's get to the really nitty gritty of all of this. And why do you think the government is doing this? Why did they propose these changes? I'm whoever wants to go first. Dr. Singh?
Sure. So I think that there's a sense that healthcare costs are rising and it has to be reined in somehow. There's also a sense that there are people who are on Medicaid who don't quote unquote deserve to be on Medicaid for whatever reason, that they're able bodied, they should be able to work, they should be able to get employer funded healthcare, or they should be able to fund more of their own care. And that's not necessarily, those things aren't necessarily true, that there's a lot of fraud in Medicaid. That has not been proven. Now, I think the other issue with the Affordable Care Act is something different. There just hasn't been a replacement for that, right? So over time, the Affordable Care Act has become less and less of a cost savings. So there has been increases in the cost of implementing that program, meaning that there was a thought that, oh, maybe we should be able to rein these costs in. Unfortunately, there has not been an alternative presented in a thoughtful, meaningful, comprehensive way that would allow for cost savings through the Affordable Care Act. So unfortunately, there is no alternative that I can currently see personally, other than simply renewing the Affordable Care Act subsidies at the rate that is required to make it affordable for people. And so how did we get here? I think it's complicated. I think the government has essentially run out of time and really hasn't had the time to debate alternatives and better ideas.
Dr. Morales, what do you think is the underlying why of all of this?
I I think Dr. Singh hit a lot of the major underlying issues that are happening right now that have most likely contributed to some of these decisions that are being made. I think a lot of it comes down to money, right? The government wants to save money. They need a cut budget, and they're trying to figure out, well, where do we get that budget cut from? But has it been well thought out? Of course not, right? Because otherwise we wouldn't be discussing all of these potentially disastrous consequences that are going to come with these legislative changes. But like Dr. Singh said, I think they're desperately trying to come up with new ideas, but they haven't had enough time, or they're reaching deadlines of creating these budget policy changes. And this is something that I feel like was for the lack of better word to say, I think it was an easy area that they felt that they could cut a lot of money from.
This is so fascinating because you say there wasn't enough time, but yet we know that certainly in Donald Trump's first term, he's gone out of his way to try and get rid of the ACA. The ACA has been in effect now for what I actually don't even know, 10, 20 years. It's been in effect for quite a long time. So why, I guess I'm confused as to why supposedly really smart, highly educated people have either not been able to come up with better systems or have felt rushed to try and do something now. And referring back to what Charlie said regarding the fact that these things have been tried in other states and were not a failure and didn't actually save money. Um, what do we make? What do we really make of that? Do we really think this is a lack of time issue, or is there something more going on? And I'm going to first ask Charlie and then maybe Dr. Morales and then Dr. Singh to weigh in on that.
Yeah. Could you repeat the question again? I just want to make sure that I'm answering.
Yeah, sorry, I sort of got lost in that. The question really is, why do you think they settled on this as a way to try and quote unquote save money when you mentioned that there have been state studies or studies done in other states where these kinds of efforts not only did not work, but didn't actually end up saving money?
I think that's a difficult question that a lot of these people who implemented this policy may have better answers for, but my understanding is that it's much more ideological, and this debate around Medicaid goes far beyond the ACA. It starts from like Newt Gingrich's area. This is a 30-year-old conversation. Every administration has looked to cut Medicaid in some kind of form, primarily because they see it as a spender, and a large spender. And I think that is a fair assessment to an extent. But you have, in any kind of policy implementation, you really have to look at the trade-offs of what you get out of a cut for this. In this case, we are looking at massive cuts to healthcare funding, millions of people falling off healthcare. And the trade-off essentially for this budget cut in Medicaid is potentially tax cuts for people who make more than seven figures, right? As a public policy trade-off, it doesn't really make a lot of sense. I can see some argument here if you say like, we're going to cut this funding and fund education or infrastructure, but that just isn't bearing out. These cuts are not going to fund any kind of public policy. And so I'm kind of left grasping at straws, trying to understand why this is really occurring, but it just doesn't make sense from a policy wonks perspective.
Dr. Morales, do you have any other thoughts on this? Given that this has been an issue for however many decades, we want to say 2 or 3 decades, I guess I don't understand the why they felt rushed to kind of do this or make these changes now.
Right. And I think it's something hard that we're all trying to like grasp our heads around. And I think there's also the aspect of, every the changes of administration that happens every couple of years when the Senate get changes or when we get a new president. It's like it reopens the conversation all over again about, well, what are we going to do about Medicaid? What are we going to do about Medicare? What are we going to do about healthcare in general? Are we going to continue the Affordable Care Act or not? And I feel like those conversations almost just get restarted, and it leads to no real solution at the end of the day. And I also, and the other thing I worry about too is in this day and age is I worry that our current administration is very focused on other areas and other topics, and healthcare has taken a backseat.
I see. I see. That's a really interesting perspective that they just, if I'm hearing you right, and please correct me if I'm not, that they just sort of maybe can't really be bothered to take on the complexity of this whole issue. And I actually wanted to ask, because we're talking a lot about Medicaid. Did they leave Medicare alone for the most part, or are there going to be changes to Medicare as well? And Dr. Singh, I'll ask you if you know the answer to that.
Yeah, great question. I think Charlie might be the better one to answer that. I believe they largely left Medicare um, alone for now. But you have to understand that people live in communities where some people have Medicaid, some people have Medicare, some people have employer based healthcare. And if you have rural health systems or health systems in general closing and failing because they know that a significant number of the people that they used to serve will no longer be able to come to their health center, that actually affects everybody in the community, right? In terms of access to care, how close your specialists are, how far you'll have to drive to get that kind of care. So everybody's affected. So even if you don't get your care through the Affordable Care Act or through Medicaid, this is something that will just affect all of us together. We're in this together, unfortunately. And unfortunately, we're not really saving money really by doing this. We know that expansion of Medicaid, full funding of the ACA has shown improved healthcare outcomes, improved surgical outcomes, earlier cancer detection and survival, increased preventative care measures, less opioid abuse related mortality. So these are things that are going to occur downstream if we actually don't fully fund healthcare. And these will be bigger costs for us later. Costs in the emergency department, people showing up with advanced cancer, and then the taxpayer being forced to kind of take on that kind of cost when all of that could have been prevented. In fact, even individuals take on more cost and personal medical debt if the healthcare is not supported in this way. There's actually studies and data that show that Medicaid funding will actually decrease up to 40% in personal health care and medical expenditures and medical debt if it's fully funded.
Charlie, do you want to? My question was, is Medicare pretty much been left alone, or is there? Does the government have they made any changes to Medicare as of yet? And if you know if they're planning on making any changes.
There haven't been any specific effects on Medicare specifically, but Dr. Singh kind of talked about it where healthcare access can be affected for these populations because if they live in a rural community and the hospitals which rely on Medicaid close, their access to care is going to be limited. In addition, there are people on Medicare and Medicaid at the same time. So if they're on Medicare, but they also use Medicaid, these Medicare enrollees can be affected. But no direct changes have been made to Medicare at the moment.
So if the worst happens, and I know right now as we're recording, there's still no decision that's been made on the ACA and extending the tax discounts for the ACA right now. By the time this podcast is released, hopefully we'll actually have the answer to that question. But if the worst happens, or the worst that you're anticipating happens, what do you foresee happening to healthcare in these rural communities? Do you think like all the hospitals will close? 50% of hospitals will close? Is there any way to know like what percentage of hospitals we think will close? And then I would like to kind of circle back around to what impact do you think that will have on anesthesiologists and the provision of anesthesia care? And I see Dr. Singh's hand up, so I will turn to her for an answer to this one.
Thank you, Rita. So, we're getting news reports from all over the country: Virginia, Washington, Kansas, Pennsylvania, Oklahoma, where CEOs of healthcare systems are thinking about what's going to happen, and actually closing facilities, and this is leading to actually closures. If you think about it, a major health center is a big economic hub for a community, right? There's a lot of people that are employed through that health system with good paying jobs. So now you're going to see not just a closure of those healthcare systems, and many of them will be in rural communities. They say more than 700 rural hospitals, up to a third of all rural hospitals, could close in the upcoming years because of all of these changes. But you're going to see a depression in that local area economically, and a lot of potentially unemployed people who used to work in healthcare, right? So that's another big problem that we're not talking about. But that leads us into the discussion about kind of what's going to happen to anesthesia and anesthesiologists, where obviously if a health system closes down, so do their surgical services, so do their operating rooms. And we already know that it's difficult to get rural communities really with staffing in terms of having a lot of anesthesiologists available to them. Now we're going to see that will just worsen over time. It'll be difficult to actually get physician anesthesia providers out in those communities. In fact, in California, 22 out of 58 counties in California are considered anesthesia deserts, where there's not enough anesthesiologists to provide the amount of care that is needed. And nationally, if you look at the national rates, something like 80% of rural communities lack anesthesiologists, and the gap is filled by other types of anesthesia providers. So as these health systems will fold and these surgical services will be cut, you'll see that specialists like surgeons, especially subspecialty surgeons and anesthesiologists, will really leave those communities, and there'll be a decrease in access to safe anesthesia care. And that's the other big worry, that it will affect us very, very directly in our field.
Dr. Morales, do you have any other thoughts about that? One third, you said one third of rural hospitals.
Yeah, up to one third, and that's the estimation. And there's lots of kind of hospital groups that are looking into this, and like we've kind of discussed before, there's concerns that maybe the states are trying to fund it. They're trying to look at other types of funding schemes, but so far a lot of places are falling short, and here in this state we will be falling short.
Dr. Morales, do you have any other thoughts on this?
Yeah. So, and it's right. So if you lose funding, right, these hospitals, how are they going to function in these locations? What are they going to do? Because someone has to consume the cost. Who consumes the cost? And if the hospital and a lot of these hospitals that are in rural areas are safety net hospitals that already a huge amount of their revenue relies on reimbursement through Medicare. So if you cut their revenue significantly, then they also have to continue to consume this uncompensated cost, because just because you make it harder for people to get Medicare and just because you cut reimbursement doesn't mean that people will not continue to need care. If anything, those healthcare disparities are only going to worsen, because patients are going to avoid getting preventative checks because they can't afford it or they don't have access. They're going to present later on in their disease course with more advanced disease and more medical comorbidities. That cost is going to have to be consumed by these hospitals and healthcare centers that can't consume anymore. And then on top of that, you add the layer of, well, how do you keep the interventional platforms running? How do you keep your anesthesia staff present? and not run them so short staffed or so lean that they're looking elsewhere for a better job or a better market in a different location. So then you start a location in areas that are already what we call anesthesia deserts, that's only going to worsen even more.
That's I had never heard that term until your CSA online first blog, Anesthesia Deserts. Do we also are there also like other deserts like surgeon deserts or emergency medicine deserts, or is that pretty unique to our field?
Yeah, I agree. I bet they are. I bet they are.
Yeah. Okay, great. Um, so I guess again, are there any solutions that any of you can think of? And let me actually, before I ask that, one other question. If the state, like I know, didn't we just pass? Well, I think that was just for our area. That wasn't actually for Medicaid. I think it was for Santa Clara Valley, which is, I'm sorry, that's where I live in Palo Alto. I know we just passed in the special election a additional tax on consumer goods of some kind. I can't remember what, to try and help support our um, safety net hospital in this area. Are there are there things that the states can do, and is there a limit to how much the states can do? Like, and I by that, and I'm sorry, and it's a little confusing question, but by that I mean like, let's say the states could put like a, I don't know, 20% tax on something, and raise the amount of money to try and support Medicaid. Would they be allowed to do that, or is that going to also be restricted um, by the federal government? And Charlie, I'll start with you on that one.
Yeah, so California has actually looked to increase reimbursement rates for Medicaid in the past, and they've done that by increasing something called the Medicaid provider tax. It's a really a convoluted loophole, but it essentially raises the amount of Medicaid funds. This bill looks to cut that provision. So the federal government recognizes that these alternative funding streams are a way to fund Medicaid, and they've kind of looked to shut that door. One thing you did hint at was that a lot of this is going to come down to a state and county level. More wealthy counties like Santa Clara, San Francisco, LA County, with larger tax bases will be able to fund public programs and resources for their more unlucky populations. But for these rural counties that don't have large tax bases where they can implement these kinds of public taxes, um, that just may not be a reality. I think the state is going to have to pick up some of these costs. They've already, again, just taken out loans, but they may look to pass a larger tax at a certain point if they feel that it's necessary to cover some of these costs. I think what's ultimately going to happen is that because the costs are going to increase, they're going to cut services in Medicaid and also reduce the number of people that are eligible for Medicaid in some instances.
Dr. Singh?
Yeah, honestly, the amount of money that is needed to float the federal and state healthcare system must come from the federal government because they have the biggest pot potentially. Right. So unless they do something bigger on their end, every state will be left to do their own thing. And so every state will lean on the individual differently. Right. So taxes or raising money some other way versus just simply letting people not have health care and force them to do a self pay kind of model, which we know doesn't really work and doesn't work well. In particular, in my field, I'm worried about the coverage that Medicaid used to provide for medication assisted treatment options for opioid use disorder, like buprenorphine, for example. About 50% of buprenorphine in this country is funded through Medicaid. I'm worried that people will not be able to get their medications, will relapse from their substance use disorder problem, and have an overdose and potentially die. And that really affects the community. It affects society. Those events are very traumatic for communities. But these are things that we should start to anticipate that will occur.
Wow, it's really hard to grasp, and I guess even though I had read your article and started thinking about this topic a little bit, hearing all of you talk about it is I find very disturbing and distressing. It almost sounds like, you know, our government, and I don't want to be political about this in any way, shape, or form, because everybody, ultimately has to believe what they want to believe. But it almost seems like this has really become a very much a tiered system, in that if you have a good paying job and you have employee funded healthcare insurance, and or you can afford it independently, then great, you get care. For everyone else, you're just gonna, I don't know, be thrown by the wayside. And that it just seems so, it seems so unfortunate and so distressing to think that we're going to be sort of throwing away a large percentage of our population because they can't afford anymore to be on Medicaid. And I know, like, even the once a year having to re-sign up for my incredibly well employee provided healthcare insurance can sometimes be hard to remember. I know there's been more than once that I've forgotten to sign up for it. I can't even imagine if you have to do this every 6 months, and then you also have to document all these other things that you were mentioning earlier that you have to document. I just wonder, if, as we close out this podcast, if you could all share some last thoughts or some last suggestions, that you may have, kind of last words on this topic. And I'll start with Dr. Morales.
So I hope that when this podcast comes out, there'll be some positivity that we'll be able to discuss as it relates to this topic. I hope that there will be some type of resolution that will not leave millions of Americans off to the side. As it stands, with all the unknowns, the greatest concern and the fear that we all have is that any progress that we have made to address healthcare disparities or improve access to care or improve quality of care, that progress is at risk of being lost. And not only is it at risk of being lost, it's that those disparities are at risk of becoming worse than what they once were several years ago, before the enactment of the Affordable Care Act. And that, I think, as a first world country, is devastating.
Yeah, absolutely. Charley, and then Dr. Singh, I'll let you have the last word of the podcast.
I want to end on a more positive note here because I think
Yay.
getting into the nitty gritty of this stuff can be a little sad. Um, these cuts are really hard, and I think we've laid out the consequences of this, especially for low income and rural communities. But I think if we really zoom out, and something that keeps me really hopeful in these times is that we're having conversations in like a completely different landscape than we were even just 15 years ago, right? If you think about it, 15 years ago, there was no Medicaid expansion. And now we have 20 million more people on healthcare in the last 15 years. We've built a safety net infrastructure that really just didn't exist before. And the fact that we're now having a debate about how to protect that is really a sign of progress, I think. Now, I think people are really fighting just to make sure that those gains that we've made stay in place. And I think regardless of what happens, I think some of that will still exist, right? And I think the overall trajectory of healthcare coverage has improved significantly in this country. So maybe it's just a reminder in these hard times that we've come a long way, and there's still a lot to improve on, but there's a lot of people working on this, and I think things will work out.
Thank you for that. And thank you for the more positive and upbeat note. That is really good to think about. As you said, that even though there will be many people who will be losing out and many communities who are losing out, we're still in a better place than we were 15, 20 years ago. And with that, I'm going to turn this over to Dr. Singh and let her have the last word on the podcast before we close out.
Yeah, thank you, everyone. I just wanted to bring it back to kind of the work of the JEDI committee, and this is why we're interested in this particular issue, is that with the underfunding of healthcare, this is going to create more disparities in our communities and in our society. for those who are rural and really heavily rely on this kind of funding, even children who really rely on this kind of funding. So it's important as healthcare providers and as doctors that we continue talking about it and we continue being vocal and working with CSA and others to really talk about this at the federal and the state level so that we can support each other and just have better healthcare outcomes for ourselves, our kids, and our communities.
Thank you all so much. This was a really thought provoking, somewhat depressing, but ultimately hopeful conversation. Thank you all for joining us for another episode of Vital Times, the CSA's podcast.